And now I'm going to discuss the modern medical options for the treatment of PH and the perspectives derived from the current clinical trials. So my disclosures first. And I wanted to start with the fact that we have targets for established therapies in PH. We know that in pulmonary arterial hypertension, you have several dysfunctions in the nitric oxide pathway, in the endothelin-1 pathway, in the prostacyclin pathway, but also in the transforming growth factor beta pathway. And thanks to a refined understanding of the dysfunctions of the endothelial cells and other components of the pulmonary vessels, new drugs have been developed, some very classic like PDE5 inhibitors, endothelin receptor antagonists, and prostacyclin derivatives, and some more recent drugs like the soluble glycoside sulfase stimulators, and more recently, the activin signaling inhibitors, which have been recently approved in Europe and in the United States as an add-on therapy for PAH. And this is very interesting because TGF-beta dysfunctions are very well known since the last 20 years, thanks to the understanding of the causes of familial pulmonary hypertension and the dysfunction in the TGF-beta superfamily. So really, 2024 has been very important because of the discovery of the efficacy of the activin signaling inhibitors developed specifically for PH. So the 7th World Symposium on Pulmonary Hypertension has a very clear guidance for pulmonary hypertension. Of course, it is not a guideline, but these are expert recommendations, and many are very similar to the guidelines published in 2022, but some recent developments, including the activin signaling inhibitor identification, have allowed to improve the proposed treatment algorithm. Regarding the supportive remains indicated, you have to perform that in stable patients who have already been treated for PH. We do not advocate for supervised exercise training in people who are not stable. Of course, and it's very important, psychological support should be provided, and our patients should be vaccinated against COVID, against flu, against pneumonia, and more recently, we should consider vaccination against the respiratory syncytial virus. So many immunizations are needed. As you all know, when the patients have fluid retention, diuretic is recommended. When the patients are hypoxemic, continuous long-term oxygen therapy is recommended. When there is anemia with iron deficiency, you should consider iron supplementation. And we still advise against pregnancy. We should recommend contraceptive advice, and we should also always consider transplantation as a possible option for patients who have severe PH and who could be eligible for transplantation, especially if they are refractory to medical therapy. So as I told you, and as you discussed recently, when you perform for the first time a right heart catheterization for pre-capillary pulmonary hypertension, which is not due to chronic thromboembolic disease, which is not due to chronic lung disease, and which is apparently idiopathic, familial, heritable, or associated with drugs and toxin, you should perform an acute vasodilatory challenge to identify the people who might be responsive to calcium channel blocker. So what we do, we propose inhaled nitric oxide at 40 ppm or 20 ppm, and the patients will be considered as acute vasodilator responders if they show a drop in mean pulmonary arterial pressure by more than 10 millimeters of mercury to to reach a mean of less than 40 millimeters of mercury, with no decline in cardiac output and no rise in wedge pressure. So that's important, and they behave as if they had a spasm of the small pulmonary arteries, and when they inhale a vasodilator, like inhaled nitric oxide or inhaled iloprost, they will show a relaxation. And that's very important because these people might be responders to calcium channel blockers. You know, calcium channel blockers are very cheap. You can use nifedipine, you can use dipiazem, you can use amlodipine, and it's very important to identify these patients who might be long-term survivors with very simple drugs. So many patients responding acutely do lose vasoreactivity over time, but in our center and worldwide, around half of the acute vasodilator responders are long-term responders with very good outcomes. Then the vasoreactive responder, as you can see on that picture from my center, you see these are years of follow-up. The long-term follow-up of calcium channel blockers are excellent with very good long-term survival as compared to the people who had long-term calcium channel blocker failure. Of course, this survival curve was historical before the availability of new treatment options, but that being said, the calcium channel blockers are doing well long-term without any further intervention. So we have in our idiopathic PH patients around 5 to 7% of people who do respond to that long-term response definition. So if you consider that some patients are not long-term vasodilator responder, you need to consider a treatment algorithm. And this is derived from the World Symposium on Pulmonary Hypertension. So once again, it is an expert opinion, but I would like to spend some time on it. So the first thing I would like to emphasize is that this is a treatment recommendation for group 1 pulmonary arterial hypertension, including idiopathic PH, irritable PH, drug and toxin associated PH, and connective tissue disease associated PH. And what is really important is that you need to remember that all the guidance we have, it is for patients with the historical definition of PH, defined by a mean pulmonary arterial pressure above 25 and not 20, and PVR above 3 and not 2. And of course, this is for patients who have no significant response on acute vasoreactivity testing, because if you have acute vasoreactivity, you should be tested first line with calcium channel blockers. So here, in the non-vasoreactive patients, you will start with risk assessment. And that's exactly what I presented at the end of my previous talk. You will see whether the patients have a good exercise testing, whether they have a good functional class, whether they have a low BNP level, whether the echo and right heart cath doesn't show indication of advanced pulmonary hypertension. And based on that, you will define whether the patient is not high risk or high risk. And in the countries which have all the treatment facilities available, for the high-risk patients who have, I remind you, more than 20% risk of mortality at 1 year, we do recommend a combination of three drugs: oral endothelin receptor antagonist, oral phosphodiesterase type 5 inhibitor, and parenteral intravenous or subcutaneous prostacyclin analog. So this is for the high-risk patients. For the non-high-risk patients, we recommend a combination of 2 oral drugs targeting endothelin 1 and nitric oxide pathway. So this is very important. Thus, you have a defined population, you have a risk assessment, and depending on the risk assessment, you will have a treatment decision. And once again, I wanted to highlight the fact that initial triple combination therapy is possible in patients who have a high risk of death, and even some people with intermediate high risk, initial risk stratification, might benefit better from the intervention with multiple initial therapy. So I wanted to remind you that we have several drugs available for PAH management. Some target the endothelin pathway, some target the nitric oxide pathway, some target the prostacyclin pathway, and some target the TGF-beta pathway. And you see that for the endothelin, there are 3 drugs available, so you cannot combine the 3 together, of course, and you have to choose one of them. And you have ambrisentan, bosentan, and macitentan available worldwide. For PDE5 inhibitors, like ERAs, they are oral drugs, sildenafil and tadalafil, and the guanylate cyclase stimulators is only one, riociguat. So 3 drugs targeting endothelin, 3 drugs targeting the NO pathway, and you have a few prostacyclin derivatives, some given by intravenous route, some given by intravenous or subcutaneous route, and some given by inhalation, and some given by oral exposure. So for the prostacyclins themselves, there are different ways to offer the treatment to patients: oral, inhaled, and subcu and intravenous. And finally, sotatercept is a new treatment approved. It is an add-on therapy. It is given at 0.3 or 0.7 milligram per kilogram subcutaneously every 3 weeks. And it is a biologic therapy, which is a ligand trap for activins and GDFs. So very interestingly, as you can see here, you have 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11 drugs available for PAH treatment. You have different formulations of treprostinil, 1, 2, 3 formulations. So at the end of the day, you have nearly 15 drugs available for the treatment of a very rare condition, which affects around 15 to 50 people per million inhabitants in your country. So a lot of drugs, but when you want to use them, initially you cannot use more than 3 drugs, and this is for the severe patients. For the severe patients, you will use intravenous or subcutaneous prostacyclin plus endothelin receptor antagonists plus PDE5 inhibitors. And at follow-up, you will consider add-on sotatercept or add-on selexipag in the people who are not treated with triple. And I will show you in a minute that you can also consider switching from PDE5 inhibitors to soluble guanylate cyclase stimulator. So many drugs, but only 4 pathways to target, and at initial treatment, 2 or 3 pathways only, the 4th one, sotatercept, being considered at follow-up in the current guidance. So the big story here is that the patients who have been treated according to their initial risk stratification, they will be followed up regularly. And the follow-up should be early in time at 3 or 4 months, and it should be repeated frequently. And the risk assessment at follow-up usually includes at least non-invasive measures, so functional class, walk distance, BNP, that's a validated risk calculator. And in intermediate risk patients, you may consider echocardiography and hemodynamics in order to supplement risk assessment and refine it. What is really important at follow-up is that you will discriminate a lot of subcategories. The treatment goal is low risk. So if you have started, for example, with 2 oral drugs because the patient was intermediate risk, for example, and at follow-up, if the patient is low risk, you continue the initial therapy without change, and you will follow the patient up every 3 to 4 months to check whether the patient is stable or not. Then if the patient is intermediate low risk, you have different possibilities according to your local availability of drugs. You may consider activin signaling inhibitor as next treatment. You can consider oral or inhaled prostacyclin in patients who were on initial double combination therapy. And you can consider a switch from PDE5 inhibitor to soluble guanylate cyclase stimulator if the patients were on PDE5 inhibitor at baseline. Then, if you are intermediate high risk, meaning that your risk of death is between 10 and 20% at 1 year, we do recommend either giving intravenous or subcutaneous prostacyclin or activin signaling inhibitors. And if the patients are still at high risk of death, remain at high risk or progress to high risk, we consider that parenteral prostacyclin remains today the first choice of therapy. And if the patients are not already on intravenous or sub-Q, or introduce activin signaling inhibitor. And that's very important. So first message, most low-risk patients at follow-up should continue initial therapy without any change. Clinical trials with oral and inhaled treprostinil included only patients on monotherapy, while studies of selexipag and sotatercept included patients on combination of 2 or 3 drugs. And transplant referral is very important for select high-risk patients at diagnosis and for intermediate high and high-risk patients at first or subsequent follow-up. So that's very important. This guidance is simplified and it helps you having better management for your patients. So you have, of course, many trials available. I'm not going to go into deep details, but some treatments seem to have a more pronounced effect on 6-minute walk distance versus others. For example, sotatercept seems to be a very good treatment for improving walk distance and for decreasing time to clinical worsening. But of course, you have different options, and depending on your own practice, your patient collaboration wanted one drug or the other, and your available drugs in your country, you may decide one or another option. As you can see here, selexipag, sotatercept, inhaled treprostinil, oral treprostinil, riociguat, depending on what is available, will give you better walk distance, time to clinical worsening, biomarker, functional class, or quality of life, and you can read through this table to decide whether one treatment is more important than the other. When you look at the literature, you have very impressive randomized controlled trials. For example, the Griffon study, published now almost 10 years ago, showed that the addition of selexipag versus placebo in PH patients, 80% on background therapy, were associated with delayed time to clinical worsening. So that's important, a risk reduction of about 40%. The prostacyclin analogs, you know, have side effects, flushing, headache, gastrointestinal side effects, jaw pain, leg pain, hypotension, dizziness, syncope, and that's always a little bit difficult to tolerate high doses of these drugs, but it varies, the side effects, according to the drugs, the route of delivery, and the patient's response to therapy itself. Now we have more recent data available from the literature, and clearly we have now a drug, sotatercept, which improves walk distance and which delays time to clinical worsening in patients on background therapy, most of them on triple combination therapy. So it seems that this treatment has a good long-term efficacy. However, you need to remember that there are more invasive and non-invasive evaluation, and that there seems to be a very interesting effect, mostly on the mean pulmonary artery pressure and less so on cardiac output. So the big thing in this, with these agents, the activin signaling inhibitor, is to certainly have a kind of anti-remodeling effect, which decreases the pressure, but without major increases in cardiac output. These new treatments, and maybe it's not available yet in your country, but it will come. It is the side effects of telangiectasia, which is quite specific, the effect of bleeding, epistaxis mostly, and the effect of increased erythrocytosis with increased hemoglobin and sometimes decreased platelet count. So you need to have in your patient population exposed to activin signaling inhibitors the knowledge that there are some drug-specific side effects like increased hemoglobin or bleeding or telangiectasia, which seem to be more important, and the patient should be informed of that. So the final thing I wanted to tell you again is that repeat follow-up risk assessment is fundamental. It will allow you to reach in the most difficult patients the maximum 4-drug combination therapy, and in the eligible patients, you will need to consider lung transplantation. So before closing, I would like to share with you that we are, I think, quite lucky to have lots of drugs available, but the treatment choice will depend upon a lot of surrounding factors. Of course, you have an objective risk stratification score as a treatment goal. You need your patient to feel better, but also to have a better risk stratification. The right heart function on imaging is certainly important, and many of you are cardiologists, and you know that a good-looking right heart is very important. You need also to consider the patient factors, age, quality of life, what is available in the country, the comorbidities, the hemodynamics, the route of delivery, and clearly when it's intravenous, it's not the same thing than oral or subcutaneous. The side effect profile is also very important to consider. So the guidelines in 2022 indicated that you had different options. The recent World Symposium proceedings have included the activin signaling inhibitors in the algorithm decision, but at the end of the day, your treatment choice will depend upon what you have available in your country, what is the presentation of the patients, what is the presentations of the hemodynamics and exercise limitation. And in fact, there is a partnership between patient and doctors in order to identify the best strategy for the patient. So I will now stop. I thank you very much once again for your invitation.